us in regards to her chances with in vitro fertilization, which in women with low ovarian reserve is usually the primary treatment. And before I get into the paper, which you see now, the abstract and my co-authors, I want to explain quickly what ovarian reserve is and how we assess it. Ovarian reserve basically represents a woman's pregnancy chance. It also represents the number of follicles and eggs she has remaining in her ovaries. And there are various ways of determining or of assessing approximately what we think this ovarian reserve is. And amongst the most frequent ways to do so are the assessment of follicle-stimulating hormone and malaria. And both of these hormones have been now used for quite a number of years, follicle-stimulating hormone really for decades, for this purpose. But both of these hormones are usually utilized in absolute values. In other words, most colleagues use cutoff values of approximately 10 millinational units per ml to distinguish normal from abnormal ovarian reserve, independent of age. But as we obviously all know, FSH increases as a woman ages. And therefore, it is really possible to assess what the normal FSH level should be at any given age. And we call this age-specific ovarian function assessment. And we can do the same thing with anti-Mullerian hormone, which in contrast to FSH, declines as a woman ages. And here too, one can establish normal ranges for each age group. And what you see here in this slide are the age-specific values that we have established for our patient population in the CHR. And they're based on 95% confidence intervals for each age group. And so we can, once we know a woman's age, we can say what the normal range of an FSH for that particular age group is and what the normal range of an AMH for that particular age group is. And we define a woman to have low functional ovarian reserve, in other words, older than she should have ovaries, if either her FSH is above where it should be for her age, or it is below where it should be for her age. So either FSH too high or AMH too low, or obviously both in combination, reflect diminished ovarian reserve. At the same time, it is also known that high anti-Mullerian hormone levels, meaning above the 95% confidence interval, has meaning because it is very frequently associated with a condition which is called polycystic ovarian disease or polycystic ovarian syndrome, which in itself is a risk factor in association with in vitro fertilization because these patients tend to produce very large egg numbers and are at risk for what is called the hyperstimulation syndrome. So, at least in regards to AMH, the upper limits are also important. I'm spending so much time on this because I want to explain that based on these normal levels, one therefore can define every patient in a study as either being normal if she both in FSH is in normal range and in AMH is in normal range for her age, or she can be either in AMH higher than normal or lower than normal, and she obviously can be in FSH either higher than normal or lower than normal. And that combined, therefore, gives you 9 potential combinations in which patients can appear. But before I come to those combinations, AMH and FSH obviously correlate quite well, as this correlation coefficient demonstrates, but they do not do so equally well at all ages, as this study we published in 2010 demonstrates, where you have different combinations of normal AMH and FSH, normal AMH, abnormal FSH, abnormal AMH, normal FSH, and both of them abnormal at different age groups. And you see there are differences between those values. But how exactly this plays out in terms of IVF outcomes has really been unknown, and we therefore decided in this study to investigate what these different combinations of AMH and FSH mean in terms of how these patients will then behave in an IVF center. And as I already mentioned, one therefore can come to 9 combinations of FSH and AMH, where either FSH is normal and AMH is low, FSH is normal, AMH is high, FSH is normal, and AMH is also normal, or obviously all the other combinations. As you can see, since we are dealing in an infertile population, by far the most frequent patient population that we are encountering in the study are those women who have a high FSH and a low AMH. So by both parameters, they have abnormally low ovarian reserve. The second frequent one are those that have high FSH and normal AMH. The third frequent one, however, to our surprise, representing over 10% of the total patient population, is a group of women representing high FSH and high AMH, which, based on what I have told you, in a way is contradictory, because high FSH obviously means low ovarian reserve, while high AMH usually means high functional ovarian reserve. And we have been for quite a while quite puzzled about this patient population because of this contradiction. Our sense has been clinically that these patients did better than one would expect from the high FSH levels, but we never had the opportunity to investigate that in detail, and that's obviously what this study is. So, amongst other outcome measures, we looked for a number of eggs produced in those IVF cycles. Obviously, all statistical assessments were done adjusted for age, implantation rates, again adjusted for age, pregnancy rates. And our center has had a long-standing interest in a gene which is called the FMR1 gene, as some also call the Fragile X gene, for which we have shown a significant effects on various reproductive aspects, including IVF pregnancy rates. And so we in this study wanted to see whether this gene in any way affects what we are seeing otherwise in the general population. And coming to the study, we looked at a total of 544 544 first IVF cycles, which led to 142 pregnancies. Considering the patient population in which the study was done, which was quite adversely selected, as we will be seeing in a moment, the established clinical pregnancy rate of 26.1% is therefore quite remarkable. Now, what we found in statistical analyses performed by our statisticians were quite significant differences between all those 9 FSH-AMH combinations. That is in itself already a very important observation, because it obviously tells you that if there are significant differences between those 9 combinations, the assessment of this combination of FSH and AMH has statistical importance. And those differences were quite significant. Those 9 groups differed to a very significant degree in the dosage of gonadotropin that they required, in egg numbers, and the number of embryos that were transferred, which is obviously reflective of how many embryos one gets in this kind of a population, and also number of embryos cryopreserved, which again is a reflection of how many embryos one had, and to a statistically much more marginal degree with implantation rate. So the fact that implantation rate is so differently affected from all these other aspects, does not surprise, because obviously FSH and AMH, representing the ovarian reserve of a woman, mostly relate to egg numbers and egg quality, and therefore embryo numbers and embryo quality. And here you see the hard data, and I won't waste much time to go into the detail. I just want to point out that all those 9 groups here, in terms of the typical patient characteristics like age, BMI, really did not differ statistically. The difference between these groups, these statistical differences, came into play in all the clinically relevant issues. So again, showing us that these different combinations of AMH and FSH have significant clinical meaning, have significant clinical relevance in predicting how well or how poorly a patient may be doing. So what our results showed, that pregnancy, in other words, being pregnant or not pregnant, differed significantly between all 9 categories, all 9 groups. But the most interesting finding for us was that the group of FSH high and AMH high, in other words, this contradictory group, amongst all 9 patient groupings, had really the most favorable IVF outcomes. So our clinical sense with this patient population representing approximately 10% of all IVF cycles, in other words, was proven, and to a much more significant degree than we even had expected. These women who had the combination of an abnormally high FSH and an abnormally high AMH had over 4 times the odds of having better oocyte yields, in other words, higher egg numbers, than the other 8 categories. And they and this finding was preserved when adjusted for the gonadotropin dose as well as patient age. And even more interestingly, this patient group of high FSH and high AMH had practically twice the odds of pregnancy than all other 8 categories. And indeed, with age adjustment, the numbers remain almost identical. So the finding of having a high FSH and a high AMH is prognostically a very favorable finding. And here you see the significant difference that I alluded to in terms of oocyte yields between this group with high FSH and AMH and the rest of the patients. Now, also very interesting, I mentioned to you briefly that our center has had a long-standing interest in the FMR1 gene, and so we added the FMR1 gene to the statistical model, and something very interesting happened. All the positive findings associated with high FSH and with high AMH completely disappeared and indeed turned to a negative of 0.7 times lower pregnancy chances if the woman had what we are calling a heterozygous normal low FMR1. I don't want to divert the subject too much towards the FMR1 gene, only so much. The FMR1 gene, we reported in quite a number of publications, seems to be quite intimately involved in how ovarian aging progresses. In other words, different genetic forms of this gene seem to be aging ovaries in a different way. And the worst genotype to have is this so-called heterozygous normal low genotype, which we have previously described in a number of publications, which is characterized by having one allele, in other words, one X chromosome with CGG repeats on the FMR1 gene in normal range between 26 and 34, while the other one is in low range, which means it is under 26. We have now in a number of studies demonstrated that this FMR1 subgenotype is associated with a lot of different, very significant clinical findings, amongst them significantly lower IVF pregnancy rates. And as this study demonstrates, this is exactly the fact here once again. Finally, high AMH levels are, as I previously mentioned, associated with polycystic ovaries. And so what we also did in this study, we looked at the 3 categories where AMH was high, combination with low FSH, normal FSH, and high FSH. And we compared those to patients which we defined amongst all of our patients as PCOS patients based on large oocyte yields. In other words, they were what we considered clinical PCOS patients. And we wanted to see what the difference was between these categories and outright PCOS patients. You see that in an infertile population like ours, true PCOS patients are relatively rare, the numbers are relatively small. But you see that they were much, much younger than all the other groups. And this is a very important point, which recently has also been made in one or two other publications in the literature. Because what this observation suggests is that PCOS, polycystic ovarian syndrome, is not a static condition. Women at young age can be very frequently showing a PCOS phenotype, but as they get older, that PCOS phenotype will disappear. In other words, PCOS is not a steady condition that a woman carries into older age. And that is very important to understand, because this brings me back to the FMR1 gene, because this subgenotype of heterozygous normal low, we a number of years ago associated with a PCOS phenotype at very young ages, but which very quickly depletes the ovaries and then at mid-age develops diminished ovarian reserve. And so this subgenotype of FMR1 gives you this kind of ovarian aging pattern that you see quite frequently in women with infertility. And as many of you will know, the question how PCOS patients do in IVF is a quite controversial one, with a number of papers suggesting they're doing just as well as anybody else, other papers suggesting that they're doing worse, and this may very well be part of the answer for these discrepancies in studies, because it all obviously comes down to when you do your IVF cycle in these patients, and based on our FMR1 work, what FMR1 genotype they have. So in conclusions, what we think our manuscript, our paper demonstrates is that we now understand what the high FSH AMH means. It means good prognosis, but only if that patient does not also carry the FMR1 heterozygous normal low subgenotype. So once again, re-emphasizing the importance of FMR1, but also suggesting that FSH may be more important in earlier follicle maturation stages than we have perceived. And once again, that fits very well into another theme which we're currently investigating in our laboratory, which is the synergistic action of FSH and androgen at very early stages of follicle maturation. And again, the importance of FMR1 obviously in ovarian. The changing of the phenotypes with PCOS, I already alluded to, very important as a clinical consideration in management. Thank you very much, and I will be happy to take questions.
Thank you, Dr. Gleicher. Now I'm going to unmute everyone, so you will be able to hear, ask questions. I'm sure you have some questions.
Hello?
Okay. Now, Gloria, do you have a question?
Yes, I have a question. I just wanted to find out. I listened to the conversation all through, and we talked more of high FSH and high AMH. What if in the presence of low AMH and high FSH? does the same apply, or what is the difference in this situation? Because from what I understand, it's that with the high FSH and the high AMH, there's better chances of pregnancy with IVF and stuff. What if in the case of when it's the opposite, low AMH and high FSH?
Yeah. Low AMH and high FSH is obviously what we expect in infertile women who have low ovarian reserve. In other words, who have aging ovaries. Whether due to the fact that they are older or whether it's due to the fact that they prematurely age their ovaries. This is not as good a prognostic situation. You will have much lower egg numbers, therefore lower embryo numbers and lower pregnancy rates. But in many ways, these are probably the patients who are most in need of appropriate clinical care. Our center has been working on women with severely diminished ovarian reserve now for many years, and we have gained a lot of important insights in recent years about how you can still improve their ovarian performance. And once again, this is not the topic of today's program, but women who have very low ovarian reserve usually have very low male hormone levels, as we recently published in Human Reproduction, and therefore restoring their male hormone levels, their testosterone level mostly, will improve their performance. And that needs to be done for weeks to months before you go into an IVF cycle. Okay?
Okay, Eka, do you have a question? Hello? Okay, let's move to Lisa. Do you have a question, Lisa?
Yes. How about low FSH and low AMH? What is the prognosis there?
Sorry, Lisa?
Okay, how about someone with a low FSH and a low AMH? Can you comment on the chances of pregnancy there?
Yeah, that's a very good question, and that is also a not infrequent combination of findings. A lower FSH is obviously a good sign, while a low AMH is a bad sign. So the answer to your question comes down to how old the woman will be. If the woman is young, meaning under age 40, then the AMH is the much more important and more accurate predictor of what's really going on. But if the woman is older, meaning above age 40, and especially above age 42, or if the woman, even if she's younger, has extremely low ovarian reserve, then the FSH becomes more important. So I can't answer your question directly because it really depends on the age of the patient and how bad her AMH is. If her AMH is undetectable at young age, then paradoxically it loses importance, and one goes with the FSH in terms of prognosis. And the same applies especially after age 42.
Thank you. I see Maya's hands up. 1 second. Maya, do you have a question? This will be the last one.
Hello, can you hear me?
Yeah.
It's Gordon, Maya's husband. We've been working on getting the FSH down, reduced it now. The last blood test showed it's lower, which is it's under 10 now. It's 9, and the AMH, of course, we'd like to see it go a little higher. And what I'm asking is, should we continue to making efforts to lower FSH, or should we just leave it well enough alone?
No,
Because it sounds like higher FSH with higher AMH is actually more positive than making more effort to get the FSH down.
We here at CHR do not subscribe to what many of our colleagues do, which is to quote unquote wait for the FSH to come down. We don't subscribe to it because the FSH is not the disease. It is not the problem. The FSH is just a symptom. The problem is the ovary. So I can bring any woman's FSH down within days into normal level by giving her estrogen. That will not change her chances in getting pregnant. What requires treatment is not the FSH, it's the ovary. And again, that's a completely different subject. Your wife seems to have diminished ovarian reserve, so my suspicion would be that she has very low male hormones, androgen levels. She will probably benefit from having her androgen levels raised. That will improve her ovarian performance, and that's what you need to go after, not lowering the FSH level.
Okay, we have time for just one more question, and there's one that came in through the question chat. So this is from Nicole. I'm gonna read. Dr. Gleicher, I have a normal FSH, but AMH just tested is 0.7. However, I'm 45 years old. What is your prognostics for me?
At age 45, pregnancy chances are obviously limited, but some 45-year-old women can still get pregnant. And from the little I know from your text, if your FSH at age 45 is normal, then you may still have a chance with using your own ovaries. As I said before in answer to one of the prior questions, at that age, FSH is much more important than AMH. So the fact that your AMH is low really does not bother me. The fact that your FSH is quote-unquote normal is somewhat encouraging. But again, obviously with a cautionary note that at age 45, it's always an uphill battle.
Okay, thank you very much everybody for attending the first ever incarnation of Fertility Insights today. If you would like to receive a reprint of the paper that was just discussed, please email me at ykizawa@chr.com that you're seeing on your screen. And if you have any follow-up questions for us, please feel free to email me as well. And have a great rest of the day, and we hope to see you again.